it's a slightly thorny issue, the politics of commissioned services, geography, particularly with regard to paediatric neurosurgery. I won't go into that too much, but I think we can all agree that part of delivering good care is getting the right people together in the right room at the right time, be they adult, pediatric, surgeon, oncology, endocrinology. So that what we need is people with the relevant expertise being able to deliver that care to the patient and their families. So this is what we're trying to deal with. This is a slightly different patient from Olivia, but this is an MRI scan looking side on at the brain. So this is the forehead. Here's the bridge of the nose. And the yellow shaded area is a craniopharyngioma. So this is the normal pituitary, which has been pushed all the way down here. And the nerves to the eyes are here, and this dark line here is an important blood vessel. So you can see these tumours are right at the very centre of the brain. And the arrows are different routes that you can actually take in terms of surgery to get to these tumours. So you can come through the top of the head using an endoscope, or even doing a more open operation with a microscope. You can come under the front of the brain through an incision, usually over the top of the head. I actually go through the eyebrow largely when I do these operations. Or you can do what I do quite a lot of, is do an operation through the nose using a telescope to get to the tumour. And there's pros and cons to all of these different routes. And I think rather than patients be funneled down one route because that is what that department does, we as doctors have to tailor the operation that's necessary based on the outcome. You know, we have to decide what is the best possible outcome for that patient, and if that cannot be done within that department, then another department has to do it, is the bottom line. And the other option we've talked about is radiotherapy, which is used in quite a lot of these tumours. So here's Olivia's story. So Olivia explained a lot more eloquently than I will about her symptoms, how she became unwell. In essence, she had a slow-growing tumour which acted a bit like a cork in a bottle. So where the tumour is located, it stopped the fluid in these normal fluid-filled spaces in the brain of draining this fluid, which normally circulates. So there was a blockage, and this fluid built up, and therefore the pressure in her head became higher and higher and higher. It makes people very unwell. They develop headaches, they vomit, they lose their eyesight, and eventually they become comatose and can die if it's untreated. And now thankfully, she was treated quickly, so she was taken to hospital. She had an urgent operation performed, which is done by both pediatric and adult neurosurgeons, where a telescope was inserted into the brain, into these fluid-filled spaces, and the cyst, so the bag of fluid that was causing the blockage, was punctured, and the fluid was drained out of it. So that cork was collapsed, and the normal fluid circulation was restored. So the actual craniopharyngioma was not directly operated on. It wasn't reduced in size. I think a biopsy was taken, which confirmed the diagnosis. And the hope was, because Olivia was only 5 at the time, that maybe a more radical operation could be avoided. There's lots of problems associated with operating on these types of tumours in young children in terms of the outcome, particularly with regard to neurodevelopmental problems and hormonal problems. And you want children to have a normal puberty, you want them to grow normally, have retained fertility, all these issues. And I think the hope was by playing it safe initially, we might avoid some of those problems. Unfortunately, the tumour grew again relatively quickly, I think within a few months, and Olivia needed another telescope operation. After the telescope operation, this was the appearance of her MRI scan. So this again is a side-on view of the brain. So water is white. So this is the frontal part of the brain, and this is the craniopharyngioma here. And it's quite dark, and it has a cyst associated with it. But the cyst is not as big as it was because it's still got a hole in it. But this is gradually enlarging over time. the cyst was getting bigger again, although it wasn't causing the obstruction that it had done previously, and that more definitive treatment was needed. So Olivia had a conventional craniotomy. You saw the slides earlier, where she had a large incision over the top of her head, and an operation performed underneath the brain to get to the tumour. Now, the important thing here is that she spent quite a long time in intensive care. It took a long time to get over this operation, and she needed radiotherapy as well. So here is the actual tumour I've outlined in yellow again. I've drawn a red line here because in amongst this area is probably her pituitary stalk, and the pituitary stalk is the main communication channel between this part of the brain and the pituitary gland. And we do our best to try and look after the pituitary stalk, because if that is damaged, the pituitary gland stops working, and you need to then replace all the hormones. You need to control the hormones so that people grow normally, go through puberty, etc. So it's quite important to try and protect that stalk. And here is the nerves to the eyes. So the difficulty with these tumours is they're surrounded by all of these really important structures, including large blood vessels here. Now, you can do surgery, but the surgery through the front of the brain is done through this tiny gap here. So that's a major blood vessel, that dark line, nerves to the eyes. And you see a very thin grey line there. That's got a Latin name called the lamina terminalis. And you can actually make a little hole in that and get into this tumour. And that was the route that was taken for surgery. Actually, a really good operation. So only a small amount of little tumour left behind there. And here's the normal pituitary. And those are the nerves to the eyes. So actually quite a successful surgery, all things considered. And then Olivia went on to have proton beam radiotherapy. Now, a few years later, unfortunately, despite three operations by that stage, and proton beam radiotherapy, we were back again with a mostly cystic but also solid recurrence of this tumour. And this is when I became aware of Olivia, and I was made aware via Marta, who I know well from we travelled together to Uzbekistan, Tashkent, where we operate on children and adults and all sorts of complicated endocrine problems as part of a sort of pro bono exchange. And also Helen emailed me directly, actually, and asked me if I could get involved in Olivia's care after her parents reached out to her. And I was invited to attend the MDT meeting, which is a team-based meeting with all the surgeons, oncologists, pediatricians, radiologists, etc. And we looked at whether it might be possible to do an operation through the nose. I think at the time Olivia was 7. Is that correct? Yeah. So it's marginal. And the reason it's marginal is when you do operations through the nose, you need a certain amount of space to work in. And the bigger the nose, the bigger the sinuses at the back of the nose, the more space you have to work. There's another problem, is that here's Olivia's CT scan. So this is the area we're trying to get to. And you see a little bit of white stuff inside where the tumour is. That's calcium. So this is a CT scan, and we're looking at the bones of the skull. And the bone covering the pituitary gland is very thick. And that would put a lot of people off trying to do an operation through the nose. But for surgeons that have done lots and lots of these operations, I've done a couple of thousand now. Mr. Thomas will have done probably slightly more than me. Whilst this is a concerning feature, it's not impossible. So if you have the right experience, you have the right instruments, the right tools, you can do surgery through the nose. And I actually did the surgery with one of our own pediatric neurosurgeons assisting me. And it went well. So here's the before, here's the after. This is the optic chiasm with a tiny nodule of tumour stuck behind it. And the reason that was left behind was for similar reasons, is that if you try and remove these bits of tumours from the optic nerves, often you cause a permanent problem with vision. So there's a compromise in terms of trying to achieve positive outcome, not causing new problems. And you can see evidence here that there's been an operation through the nose. So from Olivia's telling of the episodes, obviously she had a very different recovery, which is great. And I'm really gratified to see that she recovered so quickly. So that's what can be achieved if you allow patients access to people with the relevant expertise. And there's lots of people like me dotted around the country who can do similar sorts of surgery, but it's actually linking people up so they are able to get in touch with the right team, the right surgeon. I'll tell you a slightly different story now. So R became very unwell because of raised pressure inside the head. She had a craniopharyngioma that caused blockage, build-up of cerebrospinal fluid, water on the brain, treated with a telescope, and you see a pattern here. And here's the craniopharyngioma. Except, forget that. We know these things are going to get bigger over time. We know it's going to grow and cause further problems. The same week, R was discussed with the endocrinologists and in an MDT, and collectively we decided to go on and perform an operation through the nose. And here's the tumour in R's case. You can see here's the tumour, very similar to Olivia's. Here's the normal pituitary gland, there's the pituitary stalk. Those are the nerves to the eyes. Here's one of the important blood vessels. And you can see if you do the surgery through the nose, then you avoid all of these structures, and you actually can operate along the line, what we call the long axis, so along the tumour rather than crossing the brain to get to the tumour. For those of a squeamish nature, I'll skip this, but close your eyes. So this is a view down the endoscope, and this is part of the tumour. So we've gone through the back of the nose, we're in this part of the brain here, in front of the brainstem. This is what's called the third cranial nerve. So this is what was affected when you had your apoplexy. So this is a nerve that controls movement of the right eye. This is one of the major blood vessels of the brain. This is called the posterior communicating artery. And here is the hypothalamus. And you have to gently peel these tumours off all of these blood vessels and the hypothalamus whilst not damaging them. And this is craniopharyngioma being removed through the back of the nose. And here is the hypothalamus, So this is inside the ventricle. So you can see these tiny little flecks of calcium, and a difficult decision surgeons have to make is, do they remove every last bit of this? Because that's where the real issue happens with long-term cognitive problems, obesity, all of the hormonal problems as well. Thankfully, operation went well. So here's the normal pituitary, there's the tumour, and here's the post-operative appearance where there's the chiasm, the pituitary stalk. So what's the difference between these two stories? The difference was R was 18 when she came unwell. So still a teenager, but technically an adult. So the pathway was different. So we have a subspecialization within the adult service where I'm a designated endoscopic pituitary skull-based surgeon. And the number of patients treated within the adult service is a massive factor increased as opposed to the pediatric service. So I operate on roughly 100 patients a year with pituitary tumours or craniopharyngiomas, whereas the pediatric guys will probably maybe see 1 or 2 a year, even in a big centre like Great Ormond Street. Everyone on the team is familiar with the pathway, So all of the local endocrinologists in the region know where they go, who to refer to, what meeting they get discussed in. And this is well established now. So if you look at, there's an organisation called Get It Right First Time, which is set up initially to look at hip surgery, to try and look across the country what hip replacements were being put in, how they were being put in, and try and look at all the differences in practice and try and make sense of what was the best way forward. And they've looked at various low-volume diseases, and one of them is a very rare tumour that occurs in a similar part of the brain to the pituitary tumour called a chondrosarcoma or chordoma. And the incidence of these is 1 per million per year. And special commissioners have decided that this justifies specialist commissioning. And what that means for patients is designated centres within the UK that treat these particular tumours. So as soon as a diagnosis is made of one of these rare tumours, the patient is redirected to one of these specialist centres where people have the expertise. They've seen it all before. They know what to expect. They know how to deal with it. And craniopharyngioma is in a similar order of magnitude, yet it's very rare. And the reason all of this is thought necessary. So if you look at this, sorry, you won't be able to read it from the back. This is a graph of patients operated on for another type of pituitary tumour called Cushing's disease. And number of cases per year is along this lower axis. And you can see when you're doing small numbers, there's a big variation in outcome. It goes from very good to actually not very good. The more cases, the less variation. So therefore, the people in higher volume centres with more experience seem to more consistently get better results for patients. And there's movement now in the pituitary world to have pituitary centres of excellence, which mean we must be fulfilling certain criteria, offering certain services, but also achieving certain outcomes and doing a certain volume of surgery. So I'm sorry to make it quite surgical, showing you scans and everything else, and I'm a technician, but this is what keeps us all going, seeing these sort of pictures of people having a great outcome, living their lives in the fullest way possible. But this sort of problem needs specialist care. These low-volume, rare tumours need specialists looking after them. They need to be sent to the right centres. There's already guidance on this from Get It Right First Time for other types of diseases. And I agree completely with Helen that we need a national service for rare childhood tumours to be sent to the right specialists. And just so you don't think I'm a crazy surgeon, I also am involved in the rehab as well. So this is my dog, Frodo, who's a therapy dog. And this is in the neuro rehab gym of him interacting with a profoundly disabled child, which is in some ways as gratifying as doing the surgery. Thank you.